We have today as a speaker Chancellor Professor James Griffith, who teaches in infectious disease and microbiology in the Department of Medical Laboratory Science and has served for the last 15 years or so as the CDC appointed liaison from this campus for their reporting systems for infectious disease. He's worked with several state departments of public health over the past several years, and of course in the last several months about Ebola and its complications, both political and health related. So I'd like to introduce to you Professor James Griffith.
This is a topic that a few months ago only a few weirdo scientists like me might have known a lot about it, and now is clearly a worldwide matter of discussion. So let's start here with the geography. We're talking about sub-Saharan Africa, west of the Great Rift Valley, which is over here. And north of Angola, Zambia, which is towards the bottom of Africa, and north of the Kinshasa Highway. And let me show that a little more graphically here. The sub-Saharan Africa is that pink part. West of the Great Rift Valley, which is over there, so we're going to eliminate that part. North of Angola, Zambia, which is just above the Kalahari Desert at the bottom, and north of the Kinshasa Highway, that green dotted line is the Kinshasa Highway. It wasn't that long ago that we thought of the traditional homing place, the expectational place of the Ebola virus is in this green splotch here. And the traditional cases had been around this area, not very many, a few hundred at a time. That had been the traditional area. So now we're talking about West Africa, where you see the Senegal River, West Africa, and that part is a bit perplexing. It certainly was initially, and still is to some scientists. So here's a close-up. And the yellow dotted line is the Kinshasa Highway that goes from Kinshasa east in Africa. And the blue line is the Congo River. And here's our guy, the Ebola River, the traditional home place for these organisms. The main river systems of Africa look like this: the Niger, the Nile, the Congo, the Zambezi. And our guy is right there, that little pink guy. That's our guy. And if we were to look at the main Congo Delta, it looks like this. And if you start from central West Africa going out like this, you see all those tributaries. The Congo is the big one in the middle. And if we take a close-up of that, there's the Congo, which you can see labeled. And above that, the Ubangi. And right underneath that, the Ebola. In fact, the Ebola and the Douai, small tributaries of the Mongala River, itself a tributary of the Congo, part of this humongous delta river system in sub-Saharan Africa. So here it is during the rainy season. Dinky River. But there it is. That's the traditional homeland or the epicenter point of this virus, so we think. I'm going to talk. These are the main highway systems in Africa, and I'm going to talk about Route 7 there, the blue one in West Africa, going to have some impact on our story here. And there's the Ebola River in Central Africa, the little pink line. These are the main language families. A lot of countries in Africa, these are the main language families. And Niger-Congo A, that red splotch that goes from the central part of sub-Saharan Africa to West Africa, there's a lot of communication in there. A lot of people that are transacting with one another. There's a lot of back and forth stuff there. And the Ebola River again. And the dotted line here shows the northern border of the African transition zone, basically the spot between the Sahara desert and sub-Saharan Africa, which is more well-watered and has a lot of plant life, animal life. So that transition zone also part of the natural history here. And the Ebola River again, right over the top of that branch of the Congo. So here we are in West Africa, the area that has captured the world's attention. And these are the main countries from Guinea to Sierra Leone, Liberia, and Côte d'Ivoire, the main countries there. And very recently, the World Health Organization has calculated the epicenter of this worldwide situation that we now have, and it's right here. The very, very bottom county of Guinea, an eastern two counties or two provinces of Sierra Leone, and a northern province of Liberia. We think that's where the epicenter was. The very first patient described in epidemiologic terms as patient 0, we think is from Guinea, a 2-year-old boy, best guess. And so back to Central Africa, the Ebola River again. So here's the natural history of the organisms. 1976, we have Ebola Sudan from Zara, Sudan, 53% mortality. 1989, we have a new guy on the horizon, Ebola from Western Virginia. This Ebola virus isolated from imported monkeys from the Philippines. Okay, makes everybody think about that. 1994, we have yet another player, Ebola CI, from the Thai forest in the Côte d'Ivoire, from a chimpanzee autopsy. In 2007, we have yet another player, Ebola B from Bundabugyo, a province in Uganda. And then the big guy, back to 1976, Ebola Z from Yabuko, Zaire, now the Democratic Republic of the Congo. And that's the big guy because it has a staggering mortality rate, 88% in all of the cases of Ebola Z, the Zaire, 88%, pretty staggering. That is way more than the Black Death, okay, of the Dark Ages in Europe. Way more. So their genetic phylogeny looks like this. Here are two of the Zaire organisms, two of the Sudan organisms, and a relative that people in the scientific world are thinking about, Marburg virus. Until relatively recently, the Marburg virus was the big guy. This was the organism that people studied, the organism that people were worried about as part of the family of the African hemorrhagic fever viruses. Hemorrhagic fever. Okay, that was the guy everybody was worried about. So now it's Ebola virus. Taxonomically, and if you hear thudding on the table, that would be some of my students who have just banged their head on the table because I'm talking about taxonomy. This is a filovirus in the Baltimore classification, a group 5 negative single-strand RNA filovirus, and Ebola virus is right in there, along with Marburg virus, not an especially distant relative. And the organism looks something like this. Let me just point out a couple of things here on the bottom of the first column. This is an 80 nanometer, very skinny, by 700 to 1,000 nanometer virus. Although they have been described in various research labs as long as 14,000 nanometers. So this guy has got some give, got some play to him. And on the bottom of the other column, the mutation rate historically has been pretty low, not zero, but pretty low. We are now experiencing a time where this viruses have a tendency to mutate. All organisms do, but most organisms correct their mutations. But viruses have a tendency to mutate, and they don't correct their mutations. But they're all at different rates. The influenza virus mutates like crazy. You know, there's genetic drift and a genetic shift every once in a while, so that if you got last year's influenza vaccine, maybe it won't work for this year, that kind, because they mutate like crazy. But most other viruses mutate at a way slower rate. This guy is now starting to mutate like crazy. And we're not exactly sure why, but it is mutating. So here's what's known about this virus, where it came from, and its relationship. Ebola, the Western Virginia case, of which we have 0 human fatalities, and Ebola Z, the big guy, we think they had a common ancestor roughly 1960. Marburg and Ebola S, we think, had a common ancestor somewhere between the year 1164 and the year 1314. There was a family divergence, a higher level of the taxonomy here, about 10,000 years ago from paleoviruses, primitive viruses of hamsters and voles. And the ortholog filovirus gene sequences seem to go back to rats and mice 12 to 24 million years ago. Mammals have been associated with these kinds of organisms for at least 10 million years, probably longer. So here we have the episodes of Ebola virus. These are prior to 2014, and they're all in the Congo or Zaire, that big red country up there is Zaire. They're all there. Sudan. They're all there except for one case in the Ivory Coast, and that was a non-fatal case. That constituted, from 1976 up until 2014, 100% of all the cases clustered right there. And the Ebola River again. So when you spread all of these out, this is data from June of 2014. You have to pay attention to the timing of some of the graphics I'm going to show you. This is what we knew. So here's Ebola S, one of the 1976 guys, way at the top there. Ebola Sudan, and Ebola Z from Zaire. And you notice the Ebola Z guy has occurred at several of the outbreaks since 1976. And by June, we had good data on the Ebola virus from Guinea. So that big green line looks like it's 100% of the 2014 cases. It isn't now, but at the time, that was the health ministry that was reporting in June. So by September 9th, 2014, these were where the cases were. And again, the ones in Central Africa, no big deal. We kind of expect the organisms to be there, but it's the ones in West Africa that got everybody's attention. We certainly knew about some of the transition routes. It isn't as if the scientific community has been sitting on its hands or ignoring this. We know something about the transmission routes. We know something about the specific viruses at specific locations over a period of time. So here we are with the West African focus, June 20th, 2014. Bunch of cases, all those H's and L's represent the available hospitals, field labs that had been established by June 20th, 2014. September 19th, the case rate now looks like this. 10 days later, the case rate looks like this. And again, here is where the World Health Organization thinks the epicenter was, the very bottom of Guinea, East Sierra Leone, northern Liberia. That's where we think the epicenter was. So here we have, into the process, some established cases. And if we look at Sierra Leone, that little country, I don't know why this is not working, but the little Scaracees River, on the northern end of that river system, and the Mano Moro River at the bottom are going to circumscribe this area of intense development of these cases. And I'm just going to show you the development over a period of time. So there you go. Okay, this spread, obviously, person to person, case by case, and it just infiltrated this whole area. So by October 3rd, according to the World Health Organization, we have 1,199 cases, 739 fatalities in Guinea. That was a mortality rate of about 62%. Liberia had thousands of cases, mortality rate about 54%. Sierra Leone also had a smaller number of cases, but thousands of cases, mortality rate 26%. And below the Guinea, Liberia, Sierra Leone line, we have these are just incidental cases. Below the blue line, we only have cases because somebody flew on a plane or there was some cargo or something like that. Those were the only cases in the world. And a total of about 7,000 cases, 45% mortality. That's even below EBOS, but that's where we were. And that actually is not that atypical of the sequencing of mortality early on in an episode. This is yesterday. Official report from the World Health Organization. 52% mortality in Guinea, 38% in Liberia, 28% in Sierra Leone, and an overall mortality rate of 35%. And I will tell you that this 35% would not have been as low as it is were it not for the comparatively massive intervention by health ministries and health agencies outside of these countries. The mortality rate would have been a lot higher. Nonetheless, 13,000 cases, that's pretty big. The 2014 cases from March to July, you can see the case rate is just going up. The overall mortality rate that I mentioned before, Ebola Sudan about 53%, Ebola Zaire about 79%. This is from all of the outbreaks prior to 2014. And they're spread out like this over time. There wouldn't have been human cases of Ebola virus every single year, but over a period of time, there certainly were a bunch of cases. This is the same thing, April 14th data by country, and I'm going to add to the 2014 column on the right-hand side there, because we exceeded 8,000 cases by October 11th. Now, this line up here, the highest line, the 600 cases, the 8,000 line would be through the top of the building. Okay? It is so extraordinarily large, 8,000 cases, relative to any array of cases of Ebola virus we have ever had before, that it's really quite concerning. By August of 2014, these were the big countries. Guinea, Liberia, Sierra Leone, a smaller number of cases from those circles that you can see over there in Uganda and the Democratic Republic of the Congo. And that's by August of 2014 when that data came out. So here's the actual epidemiologic data. And scientists would describe our ability to affect the total number of cases of this virus by intervention. Let's get in there, take care of the patients that there are. Don't let them spread from person to person. So the way scientists in my field keep track of this is by epidemiologic week. So you notice the last 2 weeks of 2013, that's where the case 0 happens. The first Guinea case was in week 51 of 2013. And you can see the total number of cases there, not going up by a lot. We didn't do anything in there. The first Liberian case was in epidemiologic week 11 of 2014, and we still weren't doing anything. Médecins Sans Frontières was there from the beginning. They told us that they needed tenting and triage places and treatment places, but nobody listened to them, and they only have limited resources themselves. But so the early intervention period is over. We missed it. We didn't do it. The weeks go on. Now we have a second chance. We have the first Sierra Leone cases when there are less than 500 cases, but it's hundreds by now, hundreds of cases in week 23 of this current year. We then have the first World Health Organization situation report when we have less than 5,000 cases in week 34, and we've now had a number of health ministries reporting in people who have died from those single-digit numbers of cases. Now we have hundreds, thousands of people who have died, 50% mortality rate roughly by week 34 in August. And here we are, just updated this last night. We're in epidemiologic week 42, and we now have almost 14,000 cases. And the scary part about this is that the total number of cases is doubling every 25 days. Every 25 days. So that's where we are. This is where we're going to be down the road. And if anybody wants to fill in or guess how we're going to fill in what the numbers are going to be here, what will the world response be? Because I assure you that the health ministries in these various countries are taxed to the max. There's no more. Sierra Leone, I think, has 45 physicians. Period. That's it. They don't have any more. So I don't know. So here is the overall attack rate from April to the beginning of October, and you'll notice that the total number of cases is starting to peak up. The total number of deaths doing the same thing. This is some estimate by the European Center for Infectious Disease, and the dark green dots on the computer projected line there are actual numbers of cases. And the red dots up in the right-hand corner there, those are estimated cases from various reporting entities, the World Health Organization, the CDC, the European Center for Infectious Disease. Those are estimated cases. And we're roughly here, okay? Now over this lineup here is 10,000 cases. We've now crossed 10,000 cases. Note that this is a logarithmic projection, and the World Health Organization has predicted that by week 5 or 6 or 7 of 2015, we could be at 50,000 cases or 100,000 cases, and I have no idea what that will do to the world's economy, the fate of these countries that are besieged by this, but that's roughly where we are today. And so here we have the projected numbers for Guinea, Liberia, Sierra Leone. They all look pretty scary. They all look like they're running out of control relative to where we are today. Now, there are some conditions that favor the spread of these organisms, and they do have something to do with socioeconomic conditions. If we think about this virus as being housed or protected from humans, or we're just not likely to bump into them in the jungles of sub-Saharan Central Africa, that would be one thing. But as soon as we get into cities, the dynamic changes, and that's what happened with these West African cases. Liberia and Monrovia, they all have big numbers of cases now. So we don't exactly know how primates get filoviruses. For all the time we've been studying these, we're still guessing at it a bit. We're not exactly sure how they get it. Secondary cases, for sure, we get that. They are transmitted to mammals by blood, semen, body secretions, all of that. We know that Marburg virus can be transmitted via semen 12 months after clinical recovery. Okay, that's in apes. Okay, we don't have any human information. Ebola virus can be transmitted, has been documented by handling the sick or dead chimpanzee remains, right? So we know that can happen. Ebola transmitted to humans by body fluids, tissues, etc. This is all well documented. There is some evidence of a respiratory route, which has been taken up by some news organizations to make the case that it's a droplet spread and you can get it because somebody returning from Liberia was in the airport, you were in the airport, you breathed what they exhaled, and poof, that's not true. okay? Because 100% of the possible respiratory spread has been in non-human primates, and there is evidence to suggest that humans do not have the correct receptors for these viruses in their lungs. Okay? And we have plenty of receptors elsewhere, but you don't have the receptors there. So we do know that it can be transmitted by blood, body fluids, feces, saliva, sweat, urine, vomit, semen. The virus has been detected in breast milk, but there have been no known transmissions through human breast milk. And the virus can be transmitted via mammals, including humans, bats, monkeys, etc. Those are the transmission routes from what we know. We also know that Ebola virus is not transmitted through the air, at least to humans, water, food. I'm going to have to clarify that a little bit. It's not transmitted by mosquitoes, not transmitted by other insects. Now, maybe tomorrow somebody will discover that it is, but scientists have been studying these filoviruses for a long time, so it's not transmitted that way. Okay? And I'll have to talk about pets. Unless you lick them, you're probably okay. So the basic pathophysiologic deal here is that we're looking for some source, and in the Ebola River Valley, in that area, that's where the start of all of this is, and then some expression of transmission, and then the actual damage that happens to humans. This is the very, very first photograph ever taken of an Ebola virus by a Belgian scientist who is quite well known in this arena. This is his very first picture. So we have an enzootic cycle on the left-hand side of this. So the virus is out there in the Ebola River Valley doing what it does. And again, you notice the connection here between certain animals. And again, we don't know how it's transmitted to mammals in the enzootic arena, but clearly it eventually becomes episodic when we're going to have an epidemic, okay, a spread of these, and then mammals and other organisms get into this somehow, and then eventually on the far right, a transmission to humans. There's a lot of dotted lines here, gaps in our knowledge of understanding this. We think the fruit bat is one of the possible routes that could go along that African transition zone. So here's a fruit bat, very cute little guys. They clearly could go across the transition zone to West Africa. I don't think we have absolute epidemiologic evidence that has been the path, but they're certainly capable of it. The country of Guinea has banned the eating of fruit bats. However, they apparently make a very good soup and a pie, so it might be harder to stop this than it looks like. This is definitely a problem. Depending on where you are in sub-Saharan Africa, you may be quite tempted to go out into the wilderness area behind your hut and get something, take the skin off it, and eat it. This becomes bush meat. Okay, so this would include bats and rodents and all kinds of things like that, and there is some evidence to suggest that the skinning, the handling of bush meat, what is going to become your dinner, may be a way to transmit the virus. The range of symptoms in humans is going to include all of these systems. Systemic, muscular, joints, intestines. The one that is most dramatically described in public reports anyway are the skin rash. These are African hemorrhagic fever viruses. So here is a patient with Ebola symptoms and the skin rash. Yeah, it's really not a great disease to have. It's not something you're looking forward to. And everybody doesn't get the rash at this level, but when the healthcare workers tell you this is a horrible way to die, these people need treatment. It's pretty dramatic stuff, okay? And you want to do something for them. Fatalities, of course, a big deal. This girl has just passed away. You can see that she's bled out through her mouth. She also bled out through her ears. She bled out through her nose. And it wouldn't be unusual for Ebola patients to bleed out through every orifice they have. You just leak blood. The signs and symptoms overall look something like this: fever, headache, myalgia, malaise. And all the green ones that I've highlighted here, those are the initial symptoms. Those are the things that we're looking for in the returning people that have come to back to the United States, and we're going to, put them in a prison in a tent in a New Jersey parking lot for 21 days. And then the pink ones are going to come later. So that would include vomiting, hematemesis, which is vomiting up blood, non-bloody diarrhea, and then your blood eventually fails to clot. Okay? And notice that there aren't too many of these that are 100%. So you actually need somebody who's thinking about what's going on to sort out what is happening. You need medical and scientific people to sort this out. Eventually we get some more of these pink guys: renal failure, the maculopapular rash that I showed you, hepatic damage, and then a curious one that only happens to about 15% of the Ebola patients: hiccups. And it turns out that this is a very bad sign. You're an Ebola patient and you get hiccups. It's a very bad sign. Very poor prognosis. We're not exactly sure why, but it probably has something to do with the circulatory system. So the typical course looks like this. After contact with the virus, by day 7 to 9, that's when you might develop headache, fever, fatigue, muscle soreness. The next day, or 2 days later, spiking temperature, vomiting blood, you start to become less active. The next day after that, brain damage, bleeding from your orifices, and by the next day, you're dead or you wished you were. Okay, so this is going to develop rapidly, and that is the hallmark of the Ebola virus in humans. Now, we've been having all kinds of debates among various state governors about whether we should put somebody in a 21-day quarantine period. Well, this is from two bits of research that was done. The first one in 2007, and the other one more recently, showing exactly when people get symptomatic after contacting the virus. And you'll notice that there's some patients is day 2, day 3, day 4, but we're picking out this day 7, day 8, right? That thing that I just showed you, because that's where the big bulk of patients. But there are some patients that don't become symptomatic till day 25. Okay, but it's a really tiny number, but it's not zero. If you survive, which people do survive, more than half the people are surviving this current episode, you are likely to have loss of memory, central nervous system disorders, loss of hair. This virus leaves its marks. The actual pathophysiology is going to involve something like this. The virus gains entrance to one of your cells. It attaches, taken in by a process called macropinocytosis. The virus actually convinces your cell, take me in. That's what it does. The cell membrane buckles, in the virus goes, so you see it in that red oval there. At that point, it's in a cellular entity called an endosome, and it is greatly at risk for being dissolved. And in fact, the whole cell starts to dissolve it. Cool. Big mistake. Because as soon as the whole cell starts to dissolve it, it exposes a binding entity from the virus. The virus becomes bound to the inner membrane of the endosome, and the endosome spits it out. Now it's in the cytoplasm of the cell, exactly where it wanted to be, and it divides and divides and divides and divides. Okay, so just when you think you were getting the upper hand, that's when you start to lose. Okay? And eventually you see the virus coming out the other end times a gazillion. Now it turns out your immune system does put up a defense. Your immune system does put up a defense, but the virus divides so rapidly that your immune system can't keep up with it. Okay? So here we have an encounter with, this is the big white guy, is one of your cells that is there to defend you, and the little black guy there, that's the Ebola virus. Close up, heading towards the cell. Now this big black thing here, that's the Ebola virus. One virus going to do battle with a hapless white blood cell. One of your defenders. This white blood cell should be defending you, and it thinks it's going to. So sure enough, it lines up, and these little spiky markers here, that's exactly those surface markers on the surface of the virus. We are trying to design defenses that will stick onto those markers and keep the virus from doing what it's going to do next. And you see it's just going to approach, come in very, very close contact with your white blood cell, and your white blood cell takes it in. Okay? So that's the encounter process. Macrophages, endothelial cells lining your blood vessels, macrophages, monocytes, liver cells, they're the main targets of this virus. That's what he's shooting for. Various proteins are secreted and produced by the cell that the virus is in. A complex forms that gets the endothelial cells lining your blood vessels to stick together. That causes an immune evasion and eventually the release of stuff called TNF-alpha, tissue necrosis factor alpha, interleukin-6, interleukin-8, which normally should help you defend yourself, but in fact are going to work against you here. You get a loss of vascular integrity, hypovolemic shock because you're bleeding out. Now, we do have some ways to know that the viruses are there. Within a few days after the first symptoms, probably these lab tests will be positive. There's a reverse transcriptase PCR, polymerase chain reaction. You can isolate the viruses. There are two ways of doing ELISA testing. In the middle of the process, we have ways of identifying the viruses. You can just look for antibodies. Your immune system makes a defense. You make antibodies, and we can look for those. We can also look for the presence of the virus. We can confirm the virus being present at autopsy or after your recovery. So we surely can do that. So here we have some workers in Sierra Leone, what passes for an ambulance there, moving deceased patients around. Now on the treatment side, a lot of activity, a lot of energy given to this. The standard treatment for Ebola virus is supportive therapy. That's it. That is the standard treatment. Balancing fluids, balancing electrolytes, maintaining oxygen status, maintaining blood pressure. This is the standard approach. Treating any complicating infections. Now, things that we've attempted, or things that have been attempted, high-titered, hyperimmune, horse anti-Ebola serum that has been shown to be effective in baboons, no human studies. Monoclonal antibodies from the bone marrow of Ebola survivors, and we've actually done that. One of the first people at the University of Nebraska Medical Center was treated by a returning American physician with this. There are some promising vaccines that have been tried out in guinea pigs, no human studies yet. There is a nucleoside analog inhibitor of S-adenosyl homocysteine hydrolase, which has been tried in mice, no human studies yet. And ZMapp, the big thing that was in the news. This is a combination of 3 monoclonal antibodies that have been humanized by genetic engineering and never tried before in humans, given to patients the last few doses that they had. Now it's going to take months to make some more, and it was done only because there were positive results in a small trial with monkeys. Okay? But by the time we were going to use it on humans, we only had a few doses left. The monkeys survived if they got ZMapp within 48 hours of the infection. Now, if you remember, where are you if you're the patient 48 hours after you contract the virus? Yeah, you ain't nowhere. You don't have any symptoms, you don't have any of that. So the future use of ZMapp is in question. ZMapp is also a cold chain problem in the public health arena. Things that you have to keep cold, very hard to send into third world countries. Very hard, and ZMapp is a cold chain problem. Now, some anticipated therapy. There is a RNA interference drug called TKM Ebola, not exactly yet tried on humans. There is another drug called ABI 7537, whose development was stopped because we had federal budget cuts in the United States. We stopped doing it because it wasn't important enough to do back then. And a few other things. This light blue stuff over there, selective estrogen receptor modulators. This is a brand new approach to this, and there are some drugs available, but most of them have had no human studies whatsoever. Some have had very, very limited human studies, and we have no results yet, so we don't know if any of these are going to work. No idea. Now, on the cost side, if we take the three countries, Guyana, Liberia, and Sierra Leone, the short-term impact in 2014 is in the range of $500 billion. This is an estimate that was done several months ago, but it's in the range of, and I will tell you, these countries, Guyana, Liberia, and Sierra Leone, do not have $500 billion. They don't have that. Now, if we look at 2015, those weeks that I didn't have any data for yet because it didn't happen yet, and even I couldn't make up cool data for weeks that didn't happen. If we have a low Ebola impact, meaning we put a clamp on this, we get a handle on it, we start to treat these patients in country where they are, well, then we're talking about another 100 million or so. But if we don't do that, we're talking about another billion or so. Okay? That's what's at stake for these countries. Prevention. Governor Christie made this pretty clear. The Centers for Disease Control does have the legal authority under United States public health laws to detain any person who has ... infectious disease ... There's a lot of words in there. Okay? Unfortunately, the nurse that was returning from Liberia, she didn't have nothing. She had no temperature, she had none of the signals. I don't think she applied to the public health laws of the state of New Jersey and the United States. But anyway, the CDC, which did not put her in the tent in the parking lot, these are centers around the United States that if the Centers for Disease Control think that you have an infectious disease that impacts the public health, they can forcibly detain you against your will, and you'll notice that Boston has one. Okay, so this is one of the areas, and we get all of those eastern New England states. New York gets Vermont, Connecticut, and New York. Okay, so that's how that works. All the cases would go like that. So, overall, prevention, avoid areas of known outbreaks. Wash your hands. We don't do this anymore. We now live in the era, even healthcare professionals who wear gloves. Okay, I can't tell you how many people I've said to, you wear gloves so you think you don't have to wash your hands. All right, I'm wearing gloves. Wrong. You wash your hands anyway. But we've gotten away from that. So wash your hands. Soap and water is actually very effective at getting these viruses off a body surface, actually pretty effective. You can use alcohol, like those dispenser thingies, but it's got to be at least 60% alcohol. You have to avoid bush meat if you think you can manage that, rather than eating at the UMass cafeteria. You have to avoid contact with infected people. Okay? Follow infection control procedures and do not handle the remains. unless you are a healthcare professional and you're in a position to do that without killing yourself. Okay. Of the Ebola virus, that's an Ebola virus. I actually have something to give you if you'd like to, as you go back home to tell people that medical laboratory science professor gave you Ebola, I actually have something to give you. But this is the, and the ones that I'm giving you are anatomically correct. You know, they look exactly like this. I mentioned that this virus is 80 nanometers wide and hundreds of nanometers long, but some of them have been shown to be 14,000 nanometers long. So there's some give and take in this virus, but it does have these, it doesn't always have to look like this, but it does have these domains of its nucleosome. So this is basically the way its nucleic acid, RNA, is wrapped up, and it frequently looks like this. We think that it has something to do with the virus's ability to adsorb and then trick your defense cells into taking them in. But this is roughly a depiction of their shape. The question is, how long can the virus survive on a surface? And frankly, since this was a third world disease where all those brown people are, we haven't spent as much time as we should have in checking all of this out. But the best guess is that it can survive for hours, possibly days, somewhere in that range, depending on the circumstances, hours to days. The question is there any hint from genetics as to, the seroconversion and the relationship to, as I mentioned, mammals for sure have been associated with Ebola-like viruses, maybe not this exact guy that we have, but Ebola-like viruses for 10 million years or more. Okay? And it is curiously mutating at a faster rate now than it ever has in our limited knowledge of it since 1976. So we don't know. I'm actually curious as to the Philippine source. They have jungles too. The Philippine source of Ebola virus, because they shouldn't have been there. Survivors do have immunity, yes. And depending on how active a case that you had, for example, the first American physician from Boston who came back and was treated at the University of Nebraska Medical Center, he actually had Ebola virus. He had the disease, he had the rash, he had all of that, and they are now using his antibodies to treat other patients. He can't do it every day, but fortunately we don't have that many cases. But he can consider himself to have a fairly resilient immunity. Now we don't know how much, and he claims that he's going to go back in country. But if I were him, I would still wear the spacesuit and all that stuff. But yes, you do get immunity. And as I mentioned, your immune system is not... We originally thought that in the HIV days, in the early 1980s, that you came in contact with the HIV virus, it ravaged you, and you died, and you didn't do anything. That turned out to be false. When you have HIV, you put up a humongous immune defense. I'm not sure that we put up as robust an immune defense with Ebola virus, but you definitely put up a significant immune defense. You just lose a lot because these viruses so out-compete your cells replicating. And again, even as your phagocytes are taking them in and nibbling off the bottom of their RNA, and then they nibble off that tail end in the models that are going around, that actually makes it worse for the cell that took them in. So the defense cells die at a very high rate. Let me rephrase the question. If you are going to survive, how long will you be infectious? We know more about the front end of that than the back end. But if you actually have the disease and you survive, and we can actually measure your antibodies, we can measure IgM and IgG antibodies, we can actually measure your antibodies. Once your antibodies fall below a certain threshold level, and by then you are no longer symptomatic, you have no fever, you have none of the other symptoms of, your ability to transmit the virus is very, very low. I can't say exactly that it's zero, but I think most scientific authorities in the field think that once you are subsymptomatic and your lab tests get to the resolution level of the test, meaning we can't really see that you have a lot of, you're not making antibodies, you are relatively non-infectious. But it's not a black and white line. Not a black and white line. The bigger question that we're having are with people who have been in country, near the patients, never were symptomatic. Now we're coming back to the United States and they're not symptomatic. And we're now wondering on public TV shows, radio shows, I have been called about this, where, should we be in the same state? Should we allow them to be in the same city? Right, that kind of thing. That's ridiculous. That is scientifically ridiculous. But exactly when you have zero chance, and again, scientists, and there are lots of scientists in the room here, scientists are very hesitant to talk about zero chance, 100% chance. It's just, it's just not something we do. But zero chance of transmitting, I don't know exactly when that is. Okay? But in all probable sense, once you are below the threshold of the test and subsymptomatic, you are not transmissible. Okay, so if the Ebola patient were treated in a place where there was poor sanitation and there were rats and or mice around, could the rats and or mice spread it to other people? And I think the chances of that are extremely low. To my knowledge, there have been zero studies that have ever demonstrated anything like that. But again, since we don't know how mammals contract this in the wild, in the enzootic environment, I can't say absolutely for sure it's impossible, but there are absolutely zero studies that would suggest that would be possible. How many cases would we have to have in the United States for it to be considered a considerable outbreak? I don't know, considerable by who? If you're talking considerable by scientific standards, we'd have to have hundreds of cases. And we're never going to get to that number. That's never going to happen. If you're talking about in the public's mind, in the mind of some new Cub news reporter trying to become famous, well, we've already had enough. We currently have one case. Okay, one. And the total number of cases in the United States has been 6 total. Okay? And they all survived except one, okay? The first guy in Dallas. And the only reason he didn't survive is that he was turned away by an ER triage person with 103-degree fever in an adult. That was a big mistake. 48 hours later, he was back in the hospital, and that 48 hours made a big difference for that patient. Yeah, so we've had a grand total of 6. That's it. But we'd have to have hundreds for it to be epidemiologically significant, and we're not going to get there. Thank you very much.